All right, so we want to introduce you to the concept of prioritization, which is probably one of the most important things that you're going to do as a nurse to manage your time and address your patient's needs in the order of priority. So, who needs you to see them the most? Who needs you to see them first? What medications do you have to administer first? So, those are the concepts that we want to talk about. You're going to see a lot of your NCLEX practice questions as you go through the program focusing on prioritization. They'll give you 4 patient scenarios and ask which patient you're going to see first. Or they're going to have you rank them in order of priority based on the patient's history, medications, problems they're currently having. So we use a bunch of different concepts that kind of guide us. You guys have heard of ABCs, airway, breathing, circulation. So of course having an open airway and being able to breathe are highly important, right, to stay alive. So that's a huge principle that guides us. If a patient is having an airway problem, that's going to trump having a patient who has pain in their leg. Pain in the leg is still important, but if somebody can't breathe, that's a higher priority. We use Maslow's because we know the bottom of that pyramid, all the basic physiological needs are a higher priority than the higher level needs on that pyramid. And then we use our nursing process with our assessment, diagnosis, intervention, all that good stuff. Those things guide our planning. And then there's something else, and this is what I'm going to have you focus on for an activity this week, called prioritization pairs. So when you are looking at patients and patient scenarios, their diseases they have, their medications, etc., we want you to think about some different concepts, and we've kind of paired them up. We want you to think about, first off, is the patient stable or unstable? If they're stable, is that going to be your highest priority patient? No. If they're physiologically stable, if their vital signs are stable, or we also use the term hemodynamically stable. So their blood pressure is within normal limits, their heart rate, respiratory rate, oxygen saturation, all that good stuff is within, their normal range, then they're okay for right now. Versus the unstable patient who blood pressure is low, their heart rate's fast, they're breathing fast, their O2 sat's low. So when guiding my choice between going to see one patient or the other, I'm going to go see the unstable patient first. There's no question. All right, the next principle was expected versus unexpected. So here's something to think about. If I have a patient who has a high blood pressure, and that's one of their diseases that it's chronic, they live with it, and I go in and get their vital signs in the morning, or my tech gets their vital signs, and their blood pressure's 180 over 95. Well, that's pretty high, right? That's way out of range. But is that expected? Did they get their blood pressure medication yet? No, we haven't even administered it to them yet. They have hypertension, which means something in their body is causing their blood pressure to be elevated all the time. They take medications to lower it. We haven't given them their medication. So, shocker, yeah, their blood pressure's high right now. Versus a young person, 20, no history of hypertension. We assess their vital signs and their blood pressure's 155 over 98. All right, that's not expected. Something's going on. Something's happening with this person's body. So I'm going to go see that person before I see, or I'm as concerned about this patient. Sure, I want to get this patient their medications, don't get me wrong. But we're thinking, am I expecting this to happen with this patient's body? Or is this a totally unexpected event? Higher priority for unexpected. Actual versus potential was the next pair. So when we're thinking actual versus potential, think of your nursing diagnosis. Do they have an actual problem, or do they have a risk for problem? So do they have ineffective airway clearance? And we've listened, they've got crackles and they're coughing and their O2 sat's a little low. Or have they been in bed for a prolonged period of time? They haven't been moving around. They're at risk for some respiratory problems from not expanding their lungs well. But so far they're still okay. We haven't seen that yet, but we're going to do some interventions to help prevent that, like deep breathing, coughing, using an incentive spirometer, things like that. We're going to prevent it from happening. So I also like to say this is the risk for. So when I'm prioritizing which patient to go see, I'm going to go to the patient that has the actual problem first. Patient with the risk for, I can deal with in a little bit. Acute versus chronic, next pair. So do they have an acute problem, meaning it's new, it's a recent onset? So somebody who developed some shortness of breath and cough and fever, and they went in and the doctor diagnosed them with pneumonia, versus somebody who has maybe some COPD, emphysema, like a chronic lung disease, who came in coughing, productive, they're coughing stuff up. Their O2 sats, 90. When you learn about COPD, you'll realize a 90% O2 sat for a COPD patient is fantastic. Yay, we're okay with that. So the patient with the acute pneumonia, they have no underlying respiratory problems, having low O2 sat, versus the patient with COPD who has a low O2 sat all the time from their chronic disease. I'm going to see this person first because they're at higher risk for physiological changes based on their disease than the person that's body has adapted to their chronic disease. So with that COPD patient example, they're used to living with a low O2 sat of 90, sometimes even 88% is normal for them, sometimes even a little lower. They live like that every day and their body has adjusted. So this person's going to be a higher priority for me. The next pair, I don't know if you really call it a pair, but we say risk versus benefit. What is the risk to the other patients? If I go and see patient A, what's going to happen to patient B, C, D, and E in the short term? Are they going to be stable? Are they going to be okay while I deal with this patient? And what is the benefit to me seeing the patient with the more acute problem or the higher priority? So I have to weigh that in. If I go and see the patient who has the pneumonia and their SAT's a little low, and they're coughing, and I want to do my assessment and see what meds I can give them, and I've got 4 other patients with other medical problems, is there any risk to them waiting for my attention? And then this last idea is not really a pair. It's the extremes of age. So the very young and the very old, because of their systems and the immaturity of the very young system, especially the immune system, and the very, the decline of the extremes of age of the older person and their systems, their kidney function, heart function, liver function, everything is declining with age. So they're at potentially a higher risk for problems happening quicker because of their organ dysfunction. So I have to weigh that into my decision making. I'm hoping this is starting to make sense. This is just a general concept that we use to guide our decision making. So going back to the top, if I have a patient that's stable or patients that are stable, great, they can wait. I'm going to go to my patient that's having some instability. Something's not right. Vital signs aren't right. Breathing's not right. They're having some acute pain that started. Something's out of the ordinary. I need to go and address this patient before I see the other ones. Now, I'm not even throwing delegation into this concept, but they are tied together. And when you review the information about delegation, you'll see that as a nurse, if I have 5 patients and one's unstable, I might be in this room for 30 minutes. And that means my other 4 or 5 patients, I'm not seeing them. So I'm going to be delegating people to go and address the needs of my other patients. And when you read through the delegation information, you'll see a whole other set of criteria that we use to determine appropriate delegation. Should I send another RN, my buddy working right beside me in the hall, to check on patients 2 and 3? Can I send my UAP or CNA or patient care tech, whatever you want to call them, to go and just check on these people, make sure that they have no immediate needs? Do I need to contact the charge nurse because I have somebody that, I really need someone to go check on? I don't know. But delegation's a whole other piece of this, because if I have an unstable patient, I'm going to be in there a while possibly, or transferring them to an ICU, which takes some time to get that all organized and get them out. All right, so then the expected versus unexpected. If I expect their blood pressure is going to be high, I didn't give them their meds, oh well. I'm not going to alert the media if they're 180 over 90. I'm going to address that need and get that blood pressure down, but if their blood pressure is 158 over 98 and they didn't have hypertension, that's concerning to me. So I'm going to go with the unexpected. Actual problem versus potential problem. They've got a real problem. We need to address the real problem first and then go prevent problems from happening. Acute versus chronic. We don't definitely want to deal with acute problems versus the chronic problems. And then these again are other just concepts to think about. Are they very old, very young? If I have all the patients that are, middle-aged, this doesn't really weigh in. But if I have a bunch of 20, 30-year-olds and then I have a 90-year-old, I probably should go check on the 90-year-old if everybody's stable. I'm going to go there first. And then the risk versus benefit. Again, thinking about what's at risk if I spend some time with patient A first. Again, not being able to pull in the delegation piece right now because I don't want to confuse you. I can always delegate other people to go do stuff for me. That's part of my responsibility. All right, so in your activity, we've given you a list of 5 patients, some past medical history about each patient, some demographics, and a few medications that they're taking. And what we want you to do is go through that information. You might have to look up a few medical diagnoses you're unfamiliar with, look up a couple of drugs to find out what they are, what they're used for, etc. And then I want you to use these principles and try to figure out, based on the principles, which of these 5 patients should I see first and why? And then, okay, all right, this one seems the higher priority to me. I'm going to see them first. Well, now I've got 4 patients left. Who am I going to see next and why? And I want you to think through that. And then you're going to be posting that in our discussion board for discussion. All right? Good luck.